Thank you very much for inviting me this evening. So it was a big piece of work that I'm going to be focusing on, this systematic review. So all I can do is whistle stop you through it and invite you to read it, because you can just download it. And you can read it in bits, you know, there's tables and there's supplements and so on interlinked with it. So it's not a hideous, stressful read all at once. Okay. So I'm going to, as I just said, whip you through an overview of it and conclude with next steps for collaborative working, research, and for you as clinicians, mostly. So this is what we're talking about. And this bit's caused quite a bit of interest, actually, across quite a little swathe of countries. And we've had some responses, mostly positive, one a little grumpy, but we've managed to reply to that, and that actually was published this morning. So there is a correction, but actually it was good that those authors did spot an error in a table, so the table's been adapted and so on. So this is the beast we're talking about. Why did I kick off on this? Well, I have done a review with the Cochrane review with Elizabeth Clewett, and one can only, whilst it's fab to be working for Cochrane, it is only looking at reviewing randomized controlled trials. And I do think we have to put it to bed, any notion right now of doing a randomized controlled trial on water immersion for labour and or water birth, because it's just not feasible, it's not going to work, it's not going to be ethically okay, and it's not going to be useful because the nature of the beast is not what we need. So I wanted to get out of the cul-de-sac I felt I was in and do a review using different designs, different research designs. So that triggered me to get going on this. And what we knew already, we know from several studies over more than 1 decade, nearly, well, actually more than 2 decades now, we know there's research, clear research with a common thread, that water immersion during labour, even if a woman gets out after a while, eases her sensation of pain. She feels comfortable in it. And you'll hear more about the comfort measures psychologically from Claire anon. And she's less likely in that relaxed state, oxytocin friendly, to require augmentation. She's less fearful. She has her own personal space around her, and she's in control. So she has a good satisfaction with the birth experience. And also, we do know there's quite a bit of variations in, for example, eligibility criteria and for birth pools around the country and internationally, and also between birth settings. So there's mixed eligibility, not all founded on actual research, but belief and thoughts and best of intentions, but it's very variable. And differences between care settings and countries, and then within that, differences in practice of caring for women during labour. So thought we'd try to throw a little more light on this. So 2 key questions, and these are all in the review. What interventions, what do they typically experience, and what are the outcomes compared with similar women who labour and or give birth on land? So water versus land, similar eligibility criteria, observational studies, and so on. So to get there, we synthesized evidence that compared water immersion during labour birth on intrapartum interventions and outcomes with standard care with no water immersion. And we were keen to synthesize data relating to midwifery practices, clinical practices, and birth settings that women experience. So got a team together, and I was terribly, terribly lucky because managed to have full support from two amazing American midwives, as well as Claire here. And Charles, I know from for some time now from the Oxford Hospital. And we had several additional people to us four, and us four are Claire and myself, Jennifer van der Laan, who is an associate professor in Nevada University in Las Vegas, and Priscilla Hall, who's in Emory University in Atlanta. And they've worked together. You will see them, if you go on van der Laan and Google, you will see there are 3 very interesting systematic reviews. So she's interested in Waterbirth, and she's done these reviews on women and neonates. So got a team together, got a protocol. So this is whistle stop on Prospero, which is a site where you can register that your intention to do a systematic review, and that's helpful for other people around the world, and to contact you or not to contact you, and you to contact them. Study eligibility. We decided on study eligibility, so they were any primary quantitative design, prospective, retrospective, cohort, case control. They were published in, we wanted it from 2000 up. Any language that could be translated into English. And we did a systematic search. Well, Claire led on the search, and that was replicated. One of our healthcare librarians at Brookes replicated the search. We did data extraction, all in line with SR methodology, which means that we agree, quality assess all the studies, that we decide whether they're going to be in or out. And we do that separately, and then we come together in pairs. That's how we did it with us four. And then we analysed data, which is quite a big deal. And Jennifer led us on that. It was wonderful working with her. So synthesizing different variables with outcomes and putting them into, analysing them into odds ratio and presenting them also alongside their 95% confidence interval. Some of you who might be from Oxford, Brookes, might smile at this when they hear me say this, because I'm kind of fond of 95% confidence intervals, because I think they really matter to clinicians, because it gives you a range, and if it crosses that little magic line of no effect or effect, you know, it kind of matters. So they can matter even when things are not statistically significant. And then we did additional analysis. So I was on a big learning curve on this, because we don't do this so much, shall I say, if at all, with Cochrane in my experience. And that is trying to gauge a certainty assessment, and it's to get, we accounted that could be different variables, which are different factors. But basically, we took individual variables and tried to stratify them by various things like maternal parity, birth setting, and so on, where we could, which is a method to evaluate the presence of an effect. And then we were able, through this stratification, to identify that there are some benefits, which I'll come to water immersion, especially when conducted in a hospital setting. And then we did additional analysis to check the stability of the findings over the time frame, and to identify approximately how many studies might be needed to change a result. So I know that's rather a mouthful. I hope it made vague sense, because it is complicated. But if you look at, read the paper as well, it should help. Now, these things, because thinking about that second objective, to cloak the quantitative data, you know, augmentation, yes, no, pain relief, yes, no, etc., epidural, yes, no, and what type of birth, perineal trauma, yes, no, and what it was. We wanted to contextualize this to drive it forward. So these DAGs, so this is done obedience, structure, process, outcome. And we agreed, because there is evidence out there to suggest mode of birth can be influenced by birth setting, the tub size, maternal parity, things that can also, interventions such as augmentation, induction, epidural, continuous monitoring. So these are in supplement 2, which you can download when you're cozy at home one day, and read those. I just wanted to flag these didn't just pop out of the sky. We had several discussions on them, and they are based on evidence. So this is more of the same. Perineal trauma. We wanted to know about techniques midwives were engaging with, and practice, basically, because, you know, it still seems to pop up that waterbirth particularly might be a predisposing factor, might contribute to an increased likelihood of OASI, which is obstetric anal sphincter injury, often called 3rd or 4th degree tears. And yet no prospectively conducted research has shown this. And this is relevant to us, certainly in the UK, given that for land birth now, we are adopting much more of a hands-on, what I encountered when I was a young midwife, and maternal infection. So our last DAG is around the neonate eligibility. So obviously we were looking to examine outcomes for infants who were born at 36 completed or 37 completed weeks or more. And we know that opioids and oxytocin, synthetic oxytocin, can influence fetal well-being. So the outcomes were linked to this DAG for the neonate. Right. So as Sue very kindly set the scene for us, 36 studies, a lot of participants, and I flagged this in this colour because I was not expecting so many studies to have been undertaken in the obstetric unit setting. So we're talking hospital labour wards, delivery suites, whatever you call them. So we're talking over 70,000. So that was massive proportion of the review centred on studies undertaken in the obstetric unit setting, and not just in the UK, across a range of countries. 4 were in midwifery led, and again, a sizable number of participants, and 1 was mixed obstetric unit and home birth, 25 plus 1, nearly 30,000, towards 30,000, 26,000 rather. So Of the water immersion, just to give you this, I thought this might be helpful, and this is also in our overview in the back in the paper. 25 planned to have or had a water birth, 7 labour only, 3 studies labour and birth, and 1 study it wasn't clear. Right, so this is the only table I'll subject you to, because I thought more font, this is clearer. So what did we find? Opioid injection, so much less likely. So you see the little 95% confidence interval. I've left out the odds ratio because I didn't want to send you to sleep, possibly. So, you know, they don't cross that line of 1. That's kind of relevant. And maternal perspective of pain, a lot of women in these. Look at the episiotomy, 5 studies, 15 studies, 36,500 women consistently. Water immersion, less likely to. So women who labour in water and get out, they appear to be less likely to have an episiotomy. I find that quite interesting. And there are still some people doing episiotomies in water birth in other countries. Well, I don't know what it's like in the UK now. Postpartum hemorrhage, 15 studies, quite a sizable proportion of women there, as you can see, and it favoured water immersion. Intact perineum, again, a positive increased likelihood. Maternal satisfaction increased. So those 3 EPIs, postpartum hemorrhage and intact perineum, are starred and in bold font because they were more than 10 studies, you can see, and they went into the meta-regression analysis. So they're the only findings that we could actually subject to that analysis. Oh, wow, I'll never make it. 5 minutes. Okay, so for the neonate, no difference irrespective of setting. And we had a huge proportion of neonates, 21 studies, APGAR, fine at 5. Resus, transient tachypnea of the newborn, respiratory distress, neonatal death, no differences. And NICU admission, we didn't have data for our definition, and our definition was admitted to NICU within 24 hours of birth for 48 hours or more. And so I will come to us trying to reach standardized definitions. I'm trying to move this toolbar so I can see my last thing. More cord snaps. So we definitely, and this is a finding that was pre our review for Waterbirth, more cord snaps. However, it is important to, and I've flagged this before and other authors have, it's really important to be calm and gentle as you support little one out of the water. And it's just baby's head needs to come up, you know, and if she's on all fours, bringing her forward. Anyway, very few babies have undue suffering from this because you see the blood and you can clamp straight away. I did a study that was published in 2012, over 5,000 water births, had 20 cord snaps. 4 of those babies required observation, and 2 of those babies required a blood transfusion. So it is rare. I don't know what's happened. My thing seems to be stuck. So limitations. We had poor reporting for care model. The L is missing there. We only had pool description for 7 out of the 36 studies, which I find incredible that the intervention was not described. The induction method, how the fetal heart was monitored, and these practice issues, hands-on or third stage care, and whether the placenta and membranes for Waterbirth came out in the pool or not. So we were unable to achieve objective 2 with why we created all those DAGs, to contextualize the care, to tease out components that make good practice, to try to learn more about. I think I've got to stop, have I now?
Are you coming to the end, Ethel? We can't miss out the key message.
Well, the key message is it's safe for healthy women and babies. It can reduce intervention in an obstetric unit setting, which we did not know before this review, even though those settings had very strong fixed guidance of management of labour. And this thread of cord snapping continues, but to a very small extent. I really feel I've got to, I'm so sorry, Claire, if I intrude on your time, but I've got to say what we need to do now. We need to improve evidence translation. So without contextual information like care model, what are midwives doing, when are they doing what they're doing, and et cetera, we can't make more sense. We can't refine the evidence for water immersion, and we need to collaborate to agree on standardized definitions like postpartum hemorrhage, for example, because we know it's inevitably going to be subjective to some extent. So, you know, is it when she has a blood transfusion within 24 hours of giving birth? And I think we must inform women about the benefits, be more proactive, because there is an equity issue. And we should check how expensive or not it is if we have reduced interventions in a time when we're all cash strapped. So just to conclude, we know it's enjoyed by childbearing women. It's not going to shrink. It can reduce intervention and adverse outcomes in the hospital setting. And I think as a midwife, it has the potential to modify risk-averse preoccupation within the care culture across this and several other countries. And I think it's very important these days in our risk-averse care culture for midwives to be enabled to acquire core skills. And water allows that.